Good afternoon, everyone. We've reached the last few academic sessions for today, and we hope to keep it as informative and succinct as possible. Our current panel discussion will be on the nuances of opioid prescription while also balancing the risk of dependence. It is my honor to invite our eminent panel today, and we hope to have a very enriching discussion where they share the wealth of their experience. If I may start this discussion with our senior members, please. Arathi, madam, my first question is to you. In India, the access to opioids for cancer pain remains limited due to regulatory concerns and stigma, whereas in the US, it's the exact opposite, where they face an opioid crisis. So in your opinion, how do you think we can strike a balance between both in our country?
Actually, good afternoon, everyone. The question itself, we are not using so much of morphine at all. If you see the literature, in 2018, one article says 0.2% of people get morphine, availability of morphine. They get only 0.2% of people. And I was thinking 2018 is little older article. Let me do a newer article search. That says only 0.1% are getting access to the morphine. That means we are going backward. We are not making patients to get morphine adequately. When we have a good access to morphine, then we can think of misusing of morphine. We don't have adequate morphine availability to the needy patients. Only 0.2% get morphine, only 0.22% get palliative care, proper good palliative care. Otherwise, they are not getting at all. Only 5.8 centers of palliative care in all over India get a free access to morphine. So in this question, I feel that we have to concentrate on how do we increase the availability of patients to the needy patients. So that means we are almost 98.8% of patients are not getting morphine. How do we work on that should have been question. But still, since you asked how do we balance, it is mainly on the documentation. Once we get availability, once the food is more only, it gets wasted. No? It goes out, spills over. So patients are not getting. Probably we are very, very scared of the regulations and the rules and regulations, the stigma of getting it, and we are very scared of patient getting addicted. So with all this, we ourselves are not working on getting it more. Probably we have to go to the society. We have to enter the society to look for the needy patients. And to strike balance, of course, your main question I'm answering is this is what... the regulations, you have to monitor prescription, educating the patient and their caregivers about how to take care of the morphine solution which is given to them, and educating and multiple times of counseling and restricting the prescription only to 1 week or 15 days. All these methods can help in reducing the your balance between addiction and this one. But more than that, I think we should work on maybe after next conference when Shankara is hosting, we should maybe we'll be able to do this if the availability increases.
Thank you, ma'am. My next question is to Dinesh, sir. In your opinion, sir, what challenges do hospitals face when procuring opioids like morphine?
See, audible? Yes, I'm audible. I think. Okay. Yeah. See, being an anesthesia HOD, we know how challenging it is to get the opiates in your institution, in your institutions, mainly because these are complex and multiple challenges. See, earlier the law was such that the NDPS Act, because of that, there was multiple licensing from different agencies, and it used to take a long process. But even though now they have simplified the law and giving it to the single agency such as a drug controller now, but it is not uniform all over India. And forget about all over India, especially in our Bangalore itself, some of the hospitals are under the control of drug controller. That is, it is recognized by the medical. Whereas in our hospital, we still go through the excise department. Excise department, where they have to go to when they put an application, they have to go into the range officers From range officer, they have to go to the subdivision office, and it has to go to the collector of the exercise division, where he has to sign. Then they have to come back, and once they come back, they have to inspect. And forget about the transport, this thing between the states. From one area to my hospital is in Lanka, for example, and that drug vendor is from Double Road. From that area to have to come to our area, they need to have a transport permit. Even then, we have worked on that. We were initially, when the drug was getting out of stock, initially we were sending it very late. Nowadays we are off late. We are sending it much more earlier, 3 months back. All this, but if you want extra additional drugs, all these things, then we need to have an additional these things. Along with that, harsh penalties, isn't it? Harsh penalties has made the vendors and the hospitals, because even as minor mistakes, they can be imprisoned in jail for 10 years. So the vendors and this thing hospital, some of the institutions doesn't want to store or dispense drugs, doesn't want to apply. And again, as I said to you, and it is for the vendors, it is an process where it is laborious, as well as there is a lot of legal things. And the margin of for them revenue or this thing is very less, so they are not interested. The vendors are
It's a corporate
not interested. And next thing is misconception among
Actually,
the medical
Dr. Dinesh,
doctors.
the NDPS Act is very nice.
The
It is
NDPS Act
actually
is very-
simplified in 2014.
From 2014, they have simplified.
But it is not
but
yet implemented
it is not
completely.
implemented. They said it is not uniform all over the states, but forget about all over the states. I'm saying in our own Bangalore itself, some of the hospitals are getting through the drug controllers, whereas other institutes are not recognized. So this thing again, the misconception among ourselves. That is because lack of first thing is because of the this thing, the NDPS Act. They're afraid to prescribe because of overdosage and all those things. Second thing is because of that, it's a cycle. They have stopped. They have they don't know how to use and prescribe opiates, and only at the postgraduate level, the palliative care medicine has come nowadays, and they know how to use opiates and all. Whereas at the undergraduate level, it has not come yet. So it is a multi things which we need to, which has caused this one. It's not only the procurement, as Madam said, even though they have simplified the rules, only the rest or less than 4% of the cancer pain patients are accessible to opiates for their treatment.
So just one
Still.
addition to your point, NDPS Act is implemented in 2014, but the complete in 85 it started. But
85
when the
started,
NDPS started in 85, there is a significant drop in consumption of morphine. So the remodified amendment was done in 2014. But from 2014 till now, it is taking time to implement. From last 3-4 months from our institute, we are able to get it directly from drug controller.
Yeah.
Earlier it was between both excise and so the complete implementation will happen in few years. Probably after that it becomes more easier to take morphine.
That system is already in place in Kerala, and it is working very well through the drug control. He takes stock, and he looks into everything, and it makes them easier. So hopefully it it's uniform all over India, and it's going to get better from here.
I have an additional question, sir. In your opinion, how do you think the whole process of procurement can be made safer without compromising on safety?
See, without compromising safety, yes, procurement for one is, as Madam said, we need to be at the law.
Documentation.
Law.
The whole thing is on your documentation, how you maintain oral morphine, how do you take. You should see in our institute, the documentation is so perfect. How many cases we receive, how many you use, and it is done in front of the medical officer who is responsible for it. So that way we'll be able to safely doing it. So education and training people is very, very important here.
Yeah, you need to, that main thing, you need to be very safe. Only is we need to have a balanced law. Okay, So the balance law in the sense where we should have such that we need to provide the opiates or the morphine for the patients who really need. At the same time, we should also have a surveillance and look into where it is getting misused. Okay, this thing. So in if you say in the US and all, there was a crisis mainly because why there was a the opioid was freely available and the marketing, this pharmaceutical company marketed aggressively, but they did not say the side effects of that. They did not this is side effects of that one market this thing, and the pain medicine guys, they used to give opiates for all the patients. They didn't give it for the opiates which was required for the end stage terminal cases or palliative cases where they could have looked into or where they could have taken care. And additionally, I think we need to learning from them. We need to implement, as Madam said, monitoring, extensive monitoring system where the patients where we can look into the real time. We can look into real time where we can see if there is an the behavior, the pattern of dispensing or the pattern of some persons will go to different doctors and these things misuse and all those things we can look again. Education regarding the doctors safe use and the misconception we should from the by the these things we should be among the relatives and the patient that it when there is a drug abuse they should come forward and seek for help. That's how we can be more safe. And documentation.
Sure, sir. This
Very
question is open to the panelists. Do you feel that a national registry will be of any use?
Definitely, it will be useful.
And what about digital surveillance and digital entry of all the data so that's available everywhere
Available everywhere in palliative care?
within the country?
I think Dr. Raghu, I think Tata has digital entry of the prescription for oral morphine. We are still with papers, that's all the thing.
We have our prescription.
Because it is, as per my knowledge, I think Tata and Kerala, it is digital prescriptions are available.
Even other than opioids, our prescriptions are all digital.
Yeah, other prescriptions are digitalized in Kidwai also. I mean, even in Bangalore, many hospitals.
Even additional thing is that even after digitalization, we need to manually take a printout. We have to sign our registration number and with our employee code number.
Okay.
So that two things make a major role. Otherwise, the pharmacy doesn't dispense these medications.
Digitalization of prescription you need to do in a different way for palliative care. Actually, you need to maintain the patient privacy too. So that needs actually a lot of work through the data entry or a computer side. But that definitely will help in registering. If you have registered a patient in digital, then the chances of multiple prescriptions will be avoided. The patient can have a prescription from my side and from surgical side. So we will not have an account of it, though we do so many things, paperwork. So digitalization is definitely going to help in palliative care.
Thank you, ma'am. Thank you, sir. My next question is to Raghavendra, sir. In your opinion, could mentorship from palliative care help change the attitude of opioid phobia in the country?
Yes, definitely. So in Hinduism, there is a word, after Matrubhyo and Pitrubhyo Namaha, it is Acharyabhyo Namaha, means Gurubhyo Namaha. So if you have a mentor who knows everything, maximum, about the drug, how you are going to initiate the drug, and how you are going to prescribe, about the patient selection, when you are initiating, and what time you are going to escalate. So when the patient is not getting the pain relief. So to a maximum extent, what you can, up to what level you can stretch your opioids, and when do you want to switch over to the next opioids, or whether you want to use any alternatives or substitutes for the pain, like that. So, and even in the legal aspect, so if you have, the guru will always be better than a student. So if you have a mentor who knows much better knowledge about the legal aspects or the opioid as such usage. So definitely you will have a good confidence in yourself. See, when you have our boss in our OT complex, the confidence level what we have will be very much high, in comparison with when you are doing the case alone, right? So in that way, I think mentor definitely will make changes. And whatever you have read in your books, you will be able to implement on the clinic at that point, clinical settings, with the help of guru. So you may not be knowing when to implement whatever you have studied on a particular case. Then definitely mentorship will help you. And regarding the phobia, definitely if you don't know, the prescription of the opioids, if you have phobia towards addiction or any dependence or whatever, and then regarding the use abuse also, so your boss will tell you so when to at what extent I can go, then you can switch over. So these are things I think as structured evidence based correct teacher mentor will definitely will help you to give opioid prescriptions in a safety manner.
Aarti ma'am, would you like to weigh in?
Opioid phobia is the biggest thing I feel now in palliative care we all of us are facing. We were, as per the records, we said 0.2%. Now we have come back to 0.1%. I do not know where are we lagging in not prescribing morphine to the patients. That is why the education, as I said, we need to have a proper education, multiple times of conferences, CMEs like this, where people understand prescribing morphine is safe with a proper documentation, go slow, start with a slow, and then definitely we have to get over this opioid phobia. That is what I wanted to tell, even if my question is not there. I was thinking I should tell the audience, please get over opioid phobia and start prescribing morphine. Patient will definitely bless you all. That is the best way to reduce their pain. Get over it.
Thank you, ma'am. We've not really spoken much about dependence, probably because, as ma'am was saying, we don't get to use so much of opiates in the country. But, I mean, coming to that, Namratha ma'am, my question is to you. Do you think the pain and palliative care team can incorporate any psychological screening tool where they can screen for the risk of dependence prior to prescribing opiates?
Yeah, I think it's definitely possible, but I'm not sure whether it's possible in a high load center like Kidwai. Madam has headed
You
before.
should do it. Actually.
So, yeah. Theoretically speaking, the cage aid is the simplest form that you can incorporate, like whether the patient has felt the need to cut down. I mean, in terms of aid that is adjusted to the to the drug usage, which was basically for the alcohol dependence. Here you can ask whether you felt you have to reduce the amount of opioid to be consumed, whether you feel annoyed that people are asking you to take opioids and things like that. And definitely the multimodal approach will come into place, because the psycho-oncologists who come into place, I think here Dr. Pavitra is doing the distress thermometer for all the patients. That is to screen in the beginning whether they have other components of pain. So in cancer pain, it's a multimodal pain that comes into picture. We have 4 domains, right? Physical, psychological, emotional, and social. All these factors come into place. So here what we can look into is this, the physical and the emotional aspect of it. So when the emotional aspect comes into place, the addiction and all those factors comes in, and that is where screening is required. So screening tools, there are various of them, like the GAD for generalized anxiety distress questionnaire, and physical health questionnaire and all that, but that should be incorporated in the protocol of the hospital. In our hospital, I really don't think there is time to do that much.
It's not the question of time, actually. Patients come with so much of crisis of pain. According to the literature, addiction and dependence is not a complete contraindication to start a opioid, morphine. You have to assess the patient accordingly, and then slowly you have to, you can start morphine, and at the same time you can start on de-addiction. So pain relief becomes a main component. So hence the morphine is started even without even checking whether the patient can have addiction. because they most of the time they come with a severe pain. So that becomes a primary complaint. That is why. And we had the now they're not working here. We had Dr. Anna, who used to counsel every patient before starting morphine.
That's why it should be multimodal along with the opioids. We should have an look into the psychosocial aspects, psychological aspects of the, because most of the times the dependence or these things is because of the psychological aspect of the
That is a total pain.
These things.
That is the
And meanwhile,
concept.
we along with this opioid, if this these things, we might have to look into other modalities of pain relief like physiotherapy or yoga. All those things can benefit, and we should always have a plan of de-escalation. Always have a plan of de-escalation, but it's all based on the patient. We cannot say per se we have to do like this or like that. We need to take patient by patient and with each and every visit.
And also, like Madam stated, when we deal with cancer patients, you can't take dependence or addiction as a part of contraindication to stop an opioid, because most of them in the terminal stages, they would be, happy with the dose of opioid we're giving. You don't want to really, go back to square one and say, okay, they're becoming addicted or whatever. And I remember one specific scenario that I came across in a brief moment. I had in our OPD, Dr. Mala, she's our palliative physician. So she stated a patient who came with the amber colored bottle that we dispense with the morphine syrup, stating that it's empty every week. Okay, it's usually filled for 2 weeks. Okay, so madam told that this is a patient who will live only for days, 2 weeks, and that's why we are, entertaining this. So that shows how flexible you can be with a cancer patient. You can't treat them as a non-cancer or a chronic pain patient and say, okay, no, we are not giving you opioids. So that is one thing that I remembered and I felt we have to state.
In this context, where do you think adjuvant analgesics and interventional pain modalities come into the picture?
So we, no. It's your topic.
Your personal affinity.
Personally, yeah. So we had a talk on various talks lined up with the adjuvants and interventions. Definitely to cut down the opioid use. As you mentioned, it is the addiction is a factor that you keep into your, head when you treat. And like I said, the different domains that we are treating. One is the physical pain, which can be, treated with opioids. But what about the non-physical or the emotional aspect? That is where these adjuvants come in, and also the type of pain, that is whether it is a nociceptive or a neuropathic. If you are going on treating the nociceptive pain and ignoring the neuropathic component, going on stepping up, then that will never be, your target will never be reached. And say an example, see a breast with a lymphedema pain is a nociceptive pain in an upper limb, but the same upper limb pain due to a lung cancer may be a neuropathic component pressing upon the brachial plexus. So there the adjuvants take a higher hand over the opioids. So it's all in the domains of pain treatment that you need to use and decide what to use. And the intervention, like Dr. Prashant mentioned, it need not be step 4 is the argument now. It can be initiated well initially, in especially like CA pancreas and CA lung and rectum. That is his last concluding slide, which was a take-home thing. So that is about the interventions. Maybe madam could add.
Just add, adjuvants will, actually adjuvants is not, what is the definition of adjuvants? As such, they are not a painkiller or a reducing. So it has to be added with another pain. So we cannot compare adjuvant with a opioid or a morphine here. So you cannot compare. So adjuvants, your proper diagnosis of pain becomes important here than how adjuvant is going to reduce opioid. If your diagnosis is a neuropathic pain, you will have to add adjuvant. If your diagnosis you feel it is another type of pain, or even in neuropathic you have so many variations of pain, according to it. So adjuvants will not reduce the dosage of morphine here. Adjuvants will help in reducing that particular, the whole diagnosis of pain is very, very important. Any time palliative care patient comes, I keep telling, the students who come to me, first diagnose the pain. Your diagnosis of pain is very, very important. It is nociceptive, visceral, nociceptive with a neuropathy component, with a bony component. The component, according to that, your adjuvants has to be added.
I was discussing with my Vinod that given me this topic, and I took the help of my palliative care medicine. This thing, she came with this thing after looking into the research and all, and what they practice. She said that in the palliative care, your interventions. I'm not talking about the adjuvants. Your interventions can start at any time. Anytime. It should not be the last option. It can be the first option also. The pain relief interventions. So that was a good thing for me to get a point from her. I wanted to impart to others also.
A palliative care has to be integral part from the time patient is diagnosed cancer. It has to be from the beginning, actually, along with this additional point.
My apologies. We're actually hard pressed for time, so we'll have to limit the discussion here. Thank you so much. A big thank you to all our eminent panelists for weighing in and telling us from their wealth of experience as to how we can prescribe opioids better and to emphasize the importance of opioids in cancer pain. Thank you.
Documentation. Documentation is very important.
Documentation is the most
education. Yeah.
The floor is now open to the audience. If they have any questions.
I would like to ask about